Hello everyone, welcome to the channel The Energy Exchange. And today I'll be teaching you all about one of the most important forms of anemia worldwide, that is the iron deficiency anemia. Let us first understand the origin of the term anemia. So the word anemia comes from a Greek word anaema, which means without blood. So how do we define anemia now? Anemia is defined as a state in which the blood hemoglobin level is below the normal range for the patient's age, sex, and altitude of residence. So, when exactly do we call a patient to be anemic? We will call the patient to be anemic if the hemoglobin level in the blood of an adult male is less than 13 grams per deciliter, in a non pregnant adult female less than 12 grams per deciliter, or in a pregnant female less than 11 grams per deciliter. So what happens if there is decrease in the hemoglobin level of RBCs? As we know, iron forms an important constituent of hemoglobin as heme, and it is responsible for binding the oxygen to the RBCs, which in turn carries it across the body. So if there is decrease in the hemoglobin level, it will lead to impaired oxygen carrying capacity in the RBCs due to lesser number of oxygen molecules. So how do we classify anemia? Anemia is classified based on the cause and the morphology of the RBCs. The cause of anemia can be further classified as blood loss, which could be due to acute factors such as trauma, or chronic factors such as hookworm infestation, then inadequate RBC production due to decrease in the erythropoietin, and excessive RBC destruction as in hemolytic anemia. Whereas in RBC morphology, we can call it normocytic if the cells are normal in size, as seen in thalassemia or hemolytic anemia. Microcytic if the cells are smaller than normal, as seen in iron deficiency, or macrocytic wherein the cells are larger than size, as seen in megaloblastic anemia. Now let us come to iron deficiency anemia. So, iron deficiency anemia is regarded as the most common cause of anemia in India, and globally are about 50% of anemics, they are iron deficient. So, what are the total iron stores available in the body? Looking at the percentages, we notice that hemoglobin constitutes the maximum total iron stores in the body found in the RBCs, while ferritin and hemosiderin are stored in macrophages, constitute 25% of the total iron stores. We must not forget that in muscles, iron is also available in the form of myoglobin, which constitutes about 3 to 4% of the total iron stores. Let us understand that normal diet contains about 10 to 20 milligrams of iron, but out of that only 10% are absorbed in the body. So where does the rest of the iron go to? They are lost in the form of bile, then in stools, in menses, and in milk as lactoferrin. With that in mind, let us understand the daily dietary requirement by different age groups. So, since we understand that only 10% of the iron is absorbed by the body, it is necessary that we need to take orally iron in higher amounts. So, in an adult male, about 10 milligrams per day is necessary, while in menstruating female and pregnant and lactating female, the demands are even higher. While in menstruating female, due to blood loss, it amounts to about 18 milligrams per day requirement. In pregnant and lactating female, 40 milligrams per day is sufficient. In infants and children, the daily dietary requirement of iron amounts to 5 and 10 milligrams per day respectively. So, what are the sources of iron? The rich sources of iron are meat, which constitutes of liver, heart, kidney, and sometimes as egg yolk. The good sources can be leafy vegetables in the form of spinach, broccoli, cabbages, then pulses and cereals, fish, dried fruit, molasses and jaggery, and the poor sources of iron are milk, wheat, and polished rice. An interesting fact about milk is, due to the presence of calcium in the milk, it can also inhibit the absorption of iron in the mucosa of the gut. Therefore, while taking the iron supplements, we advise the patient to avoid consuming milk along with it. Let us understand how iron absorption takes place. So, the iron absorption, diet iron consists of heme iron found in non-vegetarian foods and ferric iron found in the vegetarian or plant sources. Heme iron constitutes 25% of the dietary iron, while ferric iron constitutes 75% of the dietary iron. So, which is the most common site for iron absorption? It is usually upper small intestine, and duodenum is found to be a more common site than jejunum. So, what is the mechanism of iron absorption now? This is the most important part we need to understand. So, the dietary iron as heme and ferric iron from the food now attempts to enter the duodenal mucosa. The heme iron manages to enter the mucosa without any form of transport channels, but ferric iron, due to its trivalent nature, is unable to enter the duodenal mucosa. So, in order to enter, it needs to be converted into the divalent form, which we call as ferrous, which is possible only because of two things: the acidic pH and one enzyme which we'll call as duodenal cytochrome B reductase. Having converted to ferrous iron, now it can enter the duodenal mucosa with the help of a channel which is known as divalent metal transporter 1, which can also transport other divalents such as zinc, magnesium, manganese, etc. With heme iron and ferrous ions together in the duodenal mucosa, either they can combine to form ferric ions for storage, or the ferrous ion alone can move out of the duodenal mucosa as per the demand through a channel which is known as ferroportin. This channel can be inhibited by hepcidin. Which is formed in the liver and acts as a master regulator of iron metabolism. While the ferric ions are stored in the mucosa, it can be converted to ferrous state with the help of ferritin or apoferritin to form as ferrous ions, and it can move out as ferroportin. Now ferrous ions, as they come out, with the help of hepcidin now converts into ferric ions, which with the help of plasma transferrin now moves to RBCs for carrying oxygen utilization as they bind to transferrin receptors, or they can move to muscles, liver and spleen and bone marrow for storage. In the muscle, it is stored as myoglobin, while in the liver and spleen and bone marrow, they are stored in macrophages in the form of ferritin and hemosiderin. Now, having understood the mechanism of iron absorption in mind, it is also necessary that too much of iron is harmful in the form of iron toxicity. So that's why the duodenal mucosa acts as a mucosal block along with the channels, as we see. This mechanism prevents the entry of excess iron in the body, and iron storage in the mucosa we see as ferritin, which is lost as shedding of the mucosa. In iron deficiency anemia, large amount is quickly transferred to the blood side. So what are the factors affecting the absorption of iron? So the factors affecting the absorption of iron are, what are the things firstly we need to understand that increase the absorption of iron? So citrates can increase alongside meat, acidic foods and various iron deficiency states, be it pathological or physiological, they can increase the iron absorption. Whereas milk, tea, phosphates, phytates and drugs in the form of antacids, H2 blockers, proton pump inhibitors and tetracyclines, they decrease the iron absorption. The other substances, as I have mentioned before, are hepcidin and transferrin, which help in regulating the iron absorption. So hepcidin, as we read before, it binds to ferroportin and destroys it, thus inhibiting its function. They are produced by liver and are the master regulators of iron metabolism. So if we notice, the increase in the hepcidin will lead to the decrease in the iron levels. And only one thing if we have to remember about transferrin is the transferrin saturation is amounting to 33%. So what are the causes of iron deficiency anemia? The causes of iron deficiency anemia are increased iron demand, which is due to rapid growth in infants, adolescents, pregnancy or in erythropoietin therapy, or by increased iron loss as seen in chronic blood loss due to hookworm infestation, acute blood loss due to trauma, then in menses or in blood donation, or by decreased iron intake or absorption in the form of inadequate diet, malabsorption, or in disease as in celiac disease, Crohn's disease, or malabsorption by surgery due to post gastrectomy or due to acute and chronic inflammation. So, what are the clinical features of anemia? Having understood all the causes and mechanism, let us understand that the symptoms are fatigue, dyspnea, the patient may complain of palpitations and chest pain, then pica, wherein the patient may have intense desire to eat items such as chalk, picophagia, they will have more tendency to eat chalk and other substances more than geophagia, that is tendency to eat soil, then soreness in the tongue such as glossitis. Then they may also complain of dizziness, headache, and irritability, while in females they may complain of polymenorrhea or amenorrhea. So far the signs are concerned, the most important sign is pallor, which can be seen in lower palpebral conjunctiva, the palms, or in the oral mucosa. The nails we may see as flattening or brittle nails, which we may term as platanichia or cholinichia. We may notice mild splenomegaly. The patient may be tachycardic and he may have cold hands and feet. One thing we need to understand that a triad of atrophic glossitis, esophageal webs, and iron deficiency anemia long standing amounts to a syndrome which is known as Plummer-Vinson syndrome. Having understood, let us go ahead with investigations. So, investigations are done on the basis of determining the cause of iron deficiency anemia, or we confirm the lab diagnosis. Determining the cause of iron deficiency anemia on the basis of age, sex, or physical findings. In case of chronic blood loss, we need to ask for stool examination to look for occult blood and hookworm infestation. We may also do sigmoidoscopy and colonoscopy. In case of upper GI bleeding, we may ask for endoscopy, or for schistosomiasis suspicion, we may go for urine examination. Whereas for doing lab diagnosis, we may go for complete blood count, wherein the hemoglobin is decreased, the mean corpuscular volume also decreases, MCH and MCHC also decreases, but the total leukocyte count remains normal. The iron studies of the blood shows serum iron and serum ferritin and serum transferrin saturation to be decreased, while total iron binding capacity and hepcidin also increases. The most important part is the peripheral blood smear. The peripheral blood smear has 4 of the following features, as I will show you in the slide. The first of all is microcytic hypochromic. So if you notice microcytic hypochromic, we may notice that they are pale and they are somewhat smaller in size than the normal counterparts. Then there are characteristic shapes such as pencil cells which are elongated and teardrop cells adopting the shape of the teardrop. The target cells which look like a target of an archery, while anisopoikilocytosis is a feature of severe iron deficiency anemia, wherein the cell size are different in a blood. We must remember that in case of iron depletion, there may be normocytic normochromic anemia initially. For bone marrow iron studies, we may find erythroid hyperplasia, and the Prussian blue stains may be negative, as it may not show any iron stores present. So, how do we manage the anemia? We may manage anemia based on treating the underlying cause in case of parasites by giving antiparasitic medication, disease in GIT such as Crohn's disease or ulcerative colitis, and to replenish the iron stores due to inadequate intake. And the other way round is to treat the iron deficiency by oral iron therapy, parenteral iron therapy, or blood transfusion in very severe cases. So before we go ahead with the medication, we must first look for non-pharmacological treatment. So how do we do that? Primarily, we may increase the intake of foods which are rich in iron, like I said, by taking good sources such as meat, which is a rich source by liver, pork or beef, then poultry, seafood, leafy green vegetables and legumes. Let's come to the important part, which is called the iron therapy, which can be either oral or it can be parenteral. The oral iron therapy, in order to decide the medication and the dosage, we first need to calculate the iron deficit in the patient. It is calculated as 2.2 into the body weight of the patient into the target hemoglobin minus the patient's current hemoglobin plus 100 in order to determine the iron stores needed. So what are the preparations present in the oral iron preparation? So we have ferrous sulfate, ferrous gluconate and ferrous fumarate, that is, they are the ferrous salts. So ferrous sulfate is a 200 milligram tablet which contains about 60 milligrams of elemental iron, wherein only 10% is absorbed, but in iron deficiency only about 20% is absorbed. The ferrous gluconate and ferrous fumarate have concentrations of about 12% iron and 33% iron respectively. The dosage of iron is about 1 tablet given 2 to 3 times per day, and we have to advise patient to avoid milk, tea or drugs such as proton pump inhibitors, tetracyclines and antacids concurrent as they take the iron tablets in order to prevent the decrease in the absorption. So what is the response on taking iron medication? We may notice the intracellular iron containing enzymes will be the first to raise. The reticulocyte count, which is the immature RBCs, they will increase by around 5 to 7 days and peaks by 10 days. And hemoglobin levels, they may increase by 1 month. They will increase by 1 month. So what are the adverse effects of oral medication? Although it is very popular amongst the patient and it is mostly advised. So the patient may complain of epigastric pain, then metallic taste may be experienced by some patients. Nausea and vomiting is common. Then the patient may complain of gastritis. Due to the astringent effect of iron, constipation may be another side effect. And in case of the syrup preparation, there can be staining of teeth and tongue. So, although ideally, oral iron preparation should be given on empty stomach for better absorption, to counteract the adverse effects, iron has to be given after food generally. So let us come to the parenteral iron therapy. So in case, what if the patient is not compliant to iron therapy? So let us go to the indications. So if the patient is non-compliant to oral iron, then the parenteral medication has to be given. Then malabsorption and interstitial bowel disease has to be the other indication. In case of severe iron deficiency anemia with chronic bleeding can be the third indication, and for rapid correction along with erythropoietin therapy, parenteral iron therapy is indicated. So what are the preparations for parenteral iron? So they are older and the newer techniques. The older medications are ferrous dextran, which is given iron, and ferrous sorbitol. And the newer medications given IV are ferrous sucrose and ferrous carboxymaltose. What is the dosage for a parenteral iron therapy? So, like oral iron, we remember it was 2.2. So, let us multiply by 2 for the same in order to remember. So, 2.2 into 2 is 4.4. So, 4.4 into the body weight of the individual into the hemoglobin deficit, which is in grams per deciliter. The hemoglobin deficit is calculated by the target hemoglobin minus the patient's current hemoglobin. So this dosage calculation is the iron for making the hemoglobin counts normal, plus we need to fill up the iron stores. So every medication always has an adverse effect. So what is the adverse effect of the parenteral medication? So there can be local or they can be systemic. So the local can be pain at the IM site, there can be skin pigmentation, or there can be sterile abscess. Whereas in systemic, there can be allergic reaction due to IV, then the patient may complain of fever, palpitation, chest pain, dyspnea, flushing and anaphylaxis. The response will be same as in oral iron therapy. With that, I conclude the topic of iron deficiency anemia, and I hope that you all have understood the topic, and I thank each and every one of you for being such a patient listener. I hope I see you guys once again to teach you with another topic. Thank you very much.